All right. Good morning, everybody. Welcome to Grand Rounds. Nice to see more people in the room. And of course, we have our virtual audience. So I'm really delighted for our Grand Round speaker today. But before we begin, I would like to respectfully acknowledge that we are located in Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. So, now more so because we are a college of health sciences, I think it's really important for us to sort of look at collaborative efforts and see, what's going on across campus. Obviously, within the college, but also outside the college. So with that, I'm just delighted to introduce our guest speaker today. So Dr. Kyra Pyke joined the University of Alberta as the Dean of Faculty of Kinesiology, Sports and Recreation in August, so has freshly arrived for 9 months or so. Prior to joining the U of A, she was professor and director of the School of Kinesiology and Health Studies at Queen's University. She completed her undergraduate training at York University and earned her master's and PhD from Queen's, followed by a postdoc fellowship at McMaster University. Her area of research is cardiovascular physiology with a focus on how everyday experiences, including exercise, psychosocial stress, and diet impact the function and structure of our arteries. So we thought that was pretty relevant in our Department of Medicine. So really excited to hear her speak. Thanks, Claire.
Thank you so much. Yeah, so thank you. Really happy to be here today and really appreciate the invitation. So we'll get started. Where my slide advance? I'm just gonna move this a little bit. There we go. Okay, and I don't have any conflicts to report. So here's my outline of my presentation today. So I'm going to talk about, just by way of introduction, the vascular endothelium and its role in vasoprotection and perfusion. I'll then talk about how we assess endothelial function in humans. We'll then go into whether and how endothelial dysfunction can predict cardiovascular disease or events. And then we'll spend the rest of the presentation talking about potential modifiers of endothelial function. And so let's start with the role of the endothelium in vasoprotection and vasomotion. So this is a schematic of a blood vessel. And we've got the single layer of endothelial cells lining the lumen of the artery. So they're right in sort of direct contact with the blood. And again, they're vasoprotective and vasoactive. And so by vasoprotective, I mean a range of functions exerted by endothelial cells that help to prevent the development and progression of atherosclerosis. And by vasoactive, I mean that the endothelial cells produce molecules that participate in causing vasodilation or vasoconstriction of our arteries. And so here is just a schematic with a little snippet of lumen, an endothelial cell, and a smooth muscle cell. And so we'll talk a little bit more about this vasoactive function of the endothelial cells. So when blood flow increases in an artery, that's going to increase the friction of the red blood cells against the endothelial cell wall. And so that results in, so that friction is, we call that shear stress. And so when shear stress increases, it's going to be sensed by sensitive membrane structures that are on the outside of that endothelial cell membrane. And when that happens, that's transduced and it results in the production of a number of different vasodilators, nitric oxide being the one that I'm going to talk about the most today. These vasodilators make their way into the vascular smooth muscle, calcium concentration reduces, and so we end up with relaxation of that vascular smooth muscle. And that manifests itself as a decreased resistance to flow in the vasculature. So we'll have increased flow, increased perfusion, oxygen delivery, and nutrient delivery to tissue. And so when I'm talking about the vasoactive and vasoprotective functions, they're really linked. And one of the key linking factors is nitric oxide, it being that vasodilatory molecule, but also playing a role in vasoprotection. So forgive my schematic here. I use this in my undergraduate lectures, but it seemed helpful enough here. So we've got the endothelium sort of on two sides if we were doing kind of a slice through an artery, and then we've just got one half of the smooth muscle here. And so this is trying to show sort of a basic development, excuse me, of an atherosclerotic lesion. So how does nitric oxide kind of intervene here? Nitric oxide will inhibit that monocyte infiltration into the vascular wall. It's going to inhibit smooth muscle cell proliferation and then migration into the lesion. And it also inhibits platelet aggregation, so complication of that lesion. And so to just sort of summarize this, this combined vasoactive and vasoprotective action of the endothelial cells, when we have endothelial dysfunction, we would expect an attenuation of vasoprotection and therefore increased vulnerability to atherosclerosis. And I'll show some data, some evidence that supports this later on. And so from this then, if we have endothelial dysfunction first, sort of leading the charge here in terms of the trajectory towards clinically significant atherosclerosis, if we're able to assess endothelial function early on, so when the arteries still look like this clean one here, maybe that can predict if someone's on a trajectory to that severe atherosclerosis. And again, we'll talk about that in a few slides. So the next thing, so if assessing endothelial function can potentially have this utility in predicting cardiovascular disease, how do we do it in humans? How do we assess it? So there are a number of different ways, so a number of different indices. One, there's sort of a collection that I would call kind of biomarkers. And so this would be where we would take a blood sample and look at circulating factors in the blood. So things like endothelial microparticles or endothelial progenitor cells, indicating sort of damage or repair processes, respectively. We can also look at a sort of more functional index of endothelial function, where we're doing something to stimulate that vasoactive function of the endothelial cells. And so we can assess this endothelial dependent vasodilation in two different types or sizes of vessels. So we can look at our conduit arteries, so the big pipes like the brachial artery or large coronary arteries. And we can also look in resistance vessels or the microvasculature, where the dilation is going to really be corresponding to perfusion. And so when we're looking at this endothelial dependent vasodilation as our index of endothelial function, we can typically do that with two different types of stimuli. So we can infuse a receptor antagonist, so something like acetylcholine, so that will bind to receptors on the endothelial cell and stimulate vasodilation. And we can also look at shear stress. So we can impose a shear stress stimulus and then look at that flow-mediated dilation that happens as a result of that. And in both cases, a larger vasodilatory response would indicate better endothelial function. And so today what I'm going to talk about is primarily conduit arteries and shear stress as a stimulus for vasodilation to look at endothelial function assessment. And that's simply because that's what I do in my research program. So looking at assessment of flow-mediated dilation, and I'm going to end up abbreviating that to FMD. Essentially, we just have to increase shear stress in a conduit artery and then measure the change in conduit artery diameter. So we've got a schematic here of a conduit and then its microvasculature. And so in order to increase shear stress, what we really need to do is reduce the downstream resistance to flow or dilate that microvasculature. And we can do that in a number of different ways. So we could infuse a vasodilator drug like adenosine or acetylcholine. We can do exercise that will cause vasodilation in the microvasculature. Or we can do an occlusion cuff for a period of time and then release it, and that causes dilation downstream and we'll get an increase in blood flow. So that would be reactive hyperemia. That's done in our peripheral arteries, not in our heart arteries. And so all of those, again, will cause this dilation in the microvasculature. When that happens, blood flow and shear stress are going to increase in that upstream conduit artery, creating a stimulus for flow-mediated dilation. So the artery will get bigger, and we can measure that increase in diameter. And again, that's our index of endothelial function. So bigger dilation, better function. So this is just an example of this being looked at in coronary arteries. And so to do that, a catheter would be inserted, and people on this call have probably done this and know more about this than I do. But a catheter would be inserted to infuse a vasodilator into a coronary artery. The artery diameter would be measured upstream with imaging. And so we can see here that the increase in coronary blood flow, which would correspond to the increase in shear stress, is correlated with the increase in coronary artery diameter. So shear stress stimulating that increase in coronary artery diameter. So that's our flow-mediated dilation. This is an invasive procedure to infuse the vasodilator, and expensive potentially with imaging, and so not always appropriate to be done in a non-patient population. So we might be interested in endothelial function in children, for example, who are currently not experiencing any cardiovascular disease or concerns, and so it wouldn't be appropriate to do this kind of investigation. So do we have some other options? And in fact, we do. And looking at peripheral endothelial function is what I do in my lab. So we can do that non-invasively, and it's most commonly done in the brachial artery in the upper arm. So again, same thing, regardless of what artery we're looking at. If we want to assess flow-mediated dilation, we need to increase shear stress and measure a change in artery diameter. So if we're going to do that in the brachial artery, the most common way that is done is with an occlusion cuff for a number of minutes, usually about 5 minutes, and then release, which results in reactive hyperemia, and that's your stimulus for flow-mediated dilation. This is a really standard test, lots of methodological guidelines for this one. This is what you'll typically see in the literature. So you would inflate this blood pressure cuff for 5 minutes. You're going to get this dilation downstream because of a myogenic response and deprivation of oxygen to that tissue. As soon as you release the cuff, then you're going to get this big increase in blood flow and shear stress. You can then measure using ultrasound with the Doppler function. You can measure blood flow velocity and determine the shear stress. And then you can measure with 2D ultrasound, you get an image of the artery and you measure the diameter. And so it looks like this. If we were to look at this graph, when you release the cuff, you get this really abrupt increase in shear stress, and then it abates pretty quickly. So it's about halfway back to baseline by about 30 seconds. And then following that, you get this increase in diameter, which again peaks and then declines fairly rapidly. So it's a really transient stimulus and response. And about a 7 to 10% change in that brachial artery diameter is a fairly normal response in a healthy population. So we measure the diameter increase. Okay, and so looking at the arm, how does that apply to sort of our clinical questions? Again, we have heart attacks, not arm attacks, so we really want to know what's happening in the heart. And so it was found reasonably early on in the pursuit of this kind of way to assess endothelial function that FMD in the brachial artery seems to predict FMD in the coronary arteries. So if we look in the arm, we're maybe finding out something about what is happening in the heart without having to do that invasive and expensive procedure. And so in my lab, we've also pursued another way of looking at peripheral endothelial function. So we reasoned that in sort of our daily lives, exercise is really how we increase blood flow in our arteries. So sort of not just exercise, but physical activity, incidental physical activity. And that's going to cause FMD in our arteries in vivo. So when we all get up from here and walk out, people online, when you get on with the rest of your day, blood flow will increase and your arteries will experience FMD. And so we wanted to know how arteries responded with that really physiologically relevant stimulus. So what we do to test this is we do a hand grip exercise. I'm showing this move because it's not exciting to look at isometric exercise where the hand doesn't move, but that's actually what we do. With that, the forearm dilates, and so blood flow and shear stress increase in that brachial artery. And the same as we would with that reactive hyperemia or RH-FMD, we can measure the shear stress stimulus and the change in artery diameter with ultrasound. And we usually do exercise at a moderate intensity for about 6 to 10 minutes. And so when we do that, we see a really sustained increase in shear stress. So the shear stress will go up and then just stay up as long as we continue to exercise. And then we'll see a corresponding sustained vasodilatory response. And once again, we can measure FMD as the peak response, but we can also look at the time course of the response and so on. And so I'll just pop on what the reactive hyperemia profiles look like to highlight just how different they are. So it really is a transient and kind of bigger in magnitude stimulus with reactive hyperemia and a different pattern of dilation than what we see with the hand grip exercise. And we've started to find evidence that these two different tests maybe tell us different things about endothelial function. And so I'll talk a little bit more about that in a few more slides. Okay, so moving on. So we know now how we can assess endothelial function in humans. Does it tell us anything about cardiovascular disease? So this is a fairly classic study looking at brachial artery FMD in patients versus controls. And so the patients all had angina. But then they were divided into having coronary artery disease or not having coronary artery disease based on angiography looking for blockage. So if patients had a more than 30% blockage in an artery, they were categorized as having coronary artery disease. And if they didn't, then they were characterized as a non-CAD patient. And we can see that the brachial artery FMD is somewhat impaired in the non-CAD patients, so the ones with angina but no blockage or no significant blockage, and then it's further impaired in the patients who had the more significant blockages, suggesting that it is that this brachial artery function is indeed kind of reflecting what's happening in the coronary arteries. And in fact, they looked at a correlation between the extent of coronary blockage. So this was the maximal stenosis, so the most stenosed artery that they found, going from 0% stenosis, so totally no blockages, all the way up to a full block. And they found that that was correlated. So the R there is 0.52. So it seems then that this brachial artery FMD reflects somewhat the extent of the atherosclerotic burden in the coronary arteries. And then what about prognostic value? So this is a more recent study, so a meta-analysis from 2015. And it included both people with existing coronary artery disease and those who as yet were disease-free. And they found that it did have some prognostic value. So a 1 standard deviation decrease in FMD was associated with a doubled risk of a cardiovascular event. And events here were considered, it could have been death due to cardiovascular causes, myocardial infarction, stroke, needing revascularization procedures, and I think onset of angina. So a number of different things were categorized as events, and this brachial artery FMD was predictive. Okay, so let's move now into talking about modifiers of endothelial function. So I'm going to talk about sort of traditional risk factors for cardiovascular disease, and then I'm also going to talk about some acute exposures and how they might influence, excuse me, endothelial function transiently. And then I'll end by talking about how exercise might influence endothelial function. So here we've got some, again, pretty classic data looking at traditional risk factors and brachial artery endothelial function. And we can see that with these risk factors, we're having a lower brachial artery FMD than without the presence of the risk factor. And we might expect that given the predictive relationship that I talked about on the previous slide. So non-smokers having a larger FMD than smokers, individuals with normal cholesterol having a higher FMD than those with hypercholesterolemia. And then this last one is children. And so children with a healthy weight having a higher flow-mediated dilation than children who were defined as having obesity, and that was a BMI in the 97th percentile. So again, a fairly consistent message that FMD is lower with risk factors. I will say that there isn't a sort of cut point FMD value, which says if you're above this, you're good, and if you're below that, you're at risk. And that's because there seems to be a lot of, despite much effort to sort of standardize how we test flow-mediated dilation, lots of methodological guidelines, lots of expertise. What can categorize sort of the impaired or risk factor FMD in one lab or study might actually be the healthy FMD magnitude in another study. So even if we look here, we've sort of got an almost 6% FMD in our risk factor group in this study, but then that's not too dissimilar from what is the healthy group or control group FMD in this other study, and that's not atypical. So I think contrary to hopes maybe at the beginning of doing FMD research, it has been sort of resistant to be categorized to have a real threshold value that we could use clinically. So it remains really a research tool. So in my lab, we were interested in this effect of risk factors on endothelial function. And we wanted to see how risk factors affected our sort of different test of endothelial function. So how would the presence of a risk factor influence our arteries' ability to have flow-mediated dilation stimulated by exercise? And so we looked at the traditional reactive hyperemia test sort of as a control to just repeat what had been done in the past. And then we did our hand grip exercise test in smokers and non-smokers. And so the brightly colored bars here, this is just sort of what we expected to find with reactive hyperemia FMD. We weren't expecting anything too exciting. And then we found no difference between the two groups, the smokers and the non-smokers. So this really surprised us. And we rationalized after looking back through the literature to compare our work with that of others, that our cohort was younger and had a shorter smoking history than a lot of the other studies. So we thought, okay, maybe the exposure just hadn't been large enough. But then, even more interestingly, we actually detected endothelial dysfunction with our hand grip exercise FMD test. And it was actually, it sort of got significantly worse over time as they continued to exercise. So the gap between these is getting bigger. So that was kind of interesting because that suggested to us that we had been able to detect endothelial dysfunction with this hand grip exercise test that would have been missed if we'd only done kind of the standard reactive hyperemia test. So we thought, all right, that's interesting. Let's do it again. So this time we recruited young, healthy, obese males. And so this was now defined as, so the controls would have had a BMI less than 25, and the obese participants had a BMI, or the participants with obesity had a BMI of over 30. So this was the standard reactive hyperemia test. And again, surprisingly, we didn't detect a difference. And again, maybe because they were quite young and otherwise healthy men. But once again, we were able to detect, again, a pretty robust difference in FMD with the hand grip exercise test that creates that sustained increase in shear stress. So this then suggested to us that, well, maybe they're telling us different things about endothelial function, and certainly that we might be able to detect something with one test that we miss with the other. So it might be helpful to kind of be doing both to get a more comprehensive sense of endothelial function. And it doesn't always go this way, that you'll have sort of the impairment with the hand grip and no impairment with reactive hyperemia. There's another study that created a sustained increase in shear stress, for example, with, I think they used, it was either heating or vasodilator infusion, and they found impaired reactive hyperemia FMD in people with high cholesterol, but intact responses to the more sustained increase in shear stress. So it does seem to depend on the sort of exposure that you're looking at, which test will be better at detecting endothelial function. But from this data, we are wondering if hand grip exercise, this FMD test, might be able to detect sort of a more modest impairment than the reactive hyperemia test, at least with some exposures. But this needs more repetition with larger studies to see if that's indeed true. So the other sort of line, I guess, of exploration, or one other line of exploration that we do in my lab, is looking at the impact of acute exposures on FMD. So the risk factors are kind of that long-term thing. We also look at little short bursts. And so, for example, of acute mental stress. So, you get stressed out in the morning, you can't find your keys, you're late for your presentation, you couldn't find the building. Those kinds of things might have happened. And so then you feel stressed out for a little bit. And so does that cause this little period of endothelial dysfunction? And maybe if that happens, once on a Friday morning, but then like not again for the next month, you're good. But if it happens Friday morning and then Friday afternoon and then Friday night and then Saturday and so on, then could it be that if you experience these kind of periods of transient endothelial dysfunction, does that result in some sort, and those are then associated with these little windows of reduced vasoprotection? Could that ultimately, cumulatively, give atherosclerosis kind of this opportunity to advance so that ultimately you end up with a more clinically significant level of endothelial dysfunction or atherosclerosis? So we don't know, but this is sort of a hypothesis that we think about and motivates our interest in part in these acute exposures. So I'll talk a little bit about that. So this study was done by Jennifer Williams, who was a master's student in my lab and is now doing a PhD at McMaster. And so she was really interested in the impact of sugar on health and sugar on vascular health in particular. And so there had been, there's sort of a fairly significant body of literature that looks at the impact of acute hyperglycemia on endothelial function, but it's mostly been done in men. And so we're also interested in women's health and the effect of sex hormones on vascular function in my lab. So we thought, let's take a look at this in women. And we decided to look at it in two different phases of the menstrual cycle. So we looked in the early follicular phase when estrogen is low, and in the late follicular phase when estrogen is high. And our rationale was that we might see a hyperglycemia-induced endothelial dysfunction in the early follicular phase with low estrogen, like we see in men, but that we might see some protection from hyperglycemia-induced endothelial dysfunction in the late follicular phase when estrogen is high. And that's because estrogen can stimulate increased nitric oxide bioavailability. So that might just support an ability to have flow-mediated dilation. And also estrogen, can act as an antioxidant. And the mechanism by which hyperglycemia impairs the endothelial function is at least in part due to increasing oxidative stress. So we did our study, and it's kind of a pattern. Our hypothesis did not bear out. We found that, so we tested FMD before, and then at various time points after ingesting 75 grams of glucose, and we found that FMD was impaired 90 minutes following ingestion, and it didn't matter which phase they were in. So it was impaired in both phases. And so this is on the bottom here is just showing the delta FMD from pre to 90 minutes post ingestion when estrogen was low and when estrogen was high. And it really wasn't very different. We weren't able to detect it as significant. There's this sort of small effect size here. So the last acute exposure that I'll talk about is shame. So this is the most recent or fairly recent research in my lab. This was led by Ellen McGarity-Shipley, who finished her PhD in the summer and is now a postdoctoral fellow. And in my lab, we've sort of in general been interested in the impact of psychosocial stress on vascular function. And we've looked at mostly acute stress, but some chronic stress as well. And shame is sort of under the umbrella of psychosocial stress. So it's sort of one type of psychosocial stress. And so shame being that feeling of sort of inferiority, inadequacy, wanting to sort of shrink away. And there is a really limited amount of research. So there's more research that looks at sort of stress in general and vascular health, but much less that looks at shame and health overall. But the body of literature that has looked at that has identified lower self-rated health with higher shame and lower life expectancy in HIV/AIDS patients if they're experiencing more shame. In terms of physiological sort of correlates, cortisol and inflammation have also been noted to be higher with shame. And this happens even acutely. And so we understood from our stress research that cortisol and inflammation can stimulate endothelial dysfunction. So that made us start to wonder whether shame might also influence endothelial dysfunction. And again, this was something that Ellen was really interested in from a healthcare perspective. She's a physiotherapist. And so Ellen designed or modified sort of an existing acute shame protocol where participants were instructed to write about their sort of most shameful experience for 30 minutes. So sort of an unpleasant intervention. So they wrote about that, and then in contrast to the control task where they just wrote about like objectively the things they did today. I brushed my teeth, I walked my dog. And so we found self-rated shame did increase in the shame task and not in the control task. So we created our stimulus. And then we did actually find impaired FMD following the shame exposure and not following control. So suggesting that this experience of shame might be impacting, have a physiological outcome and be impacting our vascular function, and maybe again, if repeated, our vascular health. And interestingly, cortisol and we looked at TNF-alpha receptors, and so those didn't increase. So it seemed that the mechanism of this decline in FMD wasn't what we were expecting, and so remains unclear what is the physiological mechanism here. So just to summarize then, risk factors seem to be associated with endothelial dysfunction, and that may result in an accelerated progression of atherosclerosis, which could then lead to things like cardiovascular disease, peripheral vascular disease, and associated events. Acute exposures can also result in endothelial dysfunction. And again, maybe with repeated acute exposures and long enough windows of transient endothelial dysfunction, that might also be important to this sort of a health-related process. And one of the things, and this is sort of what drew Ellen to, I think, the shame research, is this question about if shame can contribute to endothelial dysfunction, some of our risk factors can be associated with shame and stigma as well. And so I've got the example here of smoking and obesity. Even not so much now, there's more research on this, but public health campaigns might have sort of shamed even to try to curb smoking habits and to try to encourage weight loss. And if shame actually contributes to the endothelial dysfunction, some of what we're seeing in terms of the negative impact of these risk factors may be mediated through how we're sort of dealing with them in our society, and that's exacerbating the issue. So informative to keep looking at this, to think about how we can try to sort of do no harm in our efforts to deal with risk factors. Okay, so talking a lot about how all the bad stuff that can happen to endothelial function, how it gets worse, and we're all going to get atherosclerosis. And so let's end with how exercise training can improve endothelial function. And so this study was a meta-analysis looking at 51 randomized control trials over 2,000 participants, big age range, big training duration range, and 3 different sort of modalities of exercise. So aerobic exercise, that was the majority of the studies, resistance exercise, and then some that did a combination of aerobic and resistance exercise. And so the key takeaways, all the modalities of exercise seemed to improve endothelial function significantly. And there was a significant positive relationship between aerobic exercise intensity and endothelial function. So that's shown in the 2 top graphs. So the first one is looking at relative exercise intensity, so percent VO2 max, and the other is looking at absolute exercise intensity. And we can see that as the intensity of the exercise training stimulus increased, so too did the magnitude of FMD improvement with that exercise intervention. But there wasn't a relationship between the frequency of sessions or the session duration with aerobic exercise. So that didn't seem to have an effect on how much FMD improved. In contrast, with resistance exercise, it seemed that a greater frequency of sessions with resistance training was related to how much FMD improved rather than it being related to intensity. So it does seem, so this meta-analysis is telling us exercise has a positive effect on endothelial function, which again might describe some of the exercise's beneficial effects on cardiovascular risk overall. So in my lab, we're interested in sort of individual differences in responses to exposures, and wanted to look at the reproducibility of the impact of exercise on FMD. And so this was in collaboration with Dr. Brendan Gerd at Queen's. They were doing an exercise study, so looking at HIIT training, and they were examining reproducibility in the impact on cardiorespiratory fitness. And then we added on flow-mediated dilation measurement. And so participants engaged in these 4 weeks of high-intensity interval training. It was a 40-minute session, and it was 4 minutes at 90% of your peak capacity, and then 3 minutes at 70%, 4 minutes at 90, 3 minutes 70, 90, 70, done. And they did that 4 times a week for 4 weeks. Then there was a 3-month washout period where they were just detraining, and then they did that whole protocol all over again. So, so again, huge thank you to Brendan for conducting this entire training study, which was a significant thing to keep university students with Reading Week and summer and everything engaged in this. And so, and this is why it's hard to do 2 training studies and detrain in the middle, which is why there aren't really many studies that look at this. So. So we found repeatability at the group level. So the amount that FMD improved during the first period of training wasn't different from the amount that FMD improved during the second period of training. And FMD really did, it returned to kind of the baseline pre-training levels over that 3-month detraining period. But then I think even more interestingly, the amount that FMD improved in the first period of training, so that first 4 weeks, predicted the amount that FMD improved in that second training period. So they were correlated. And if we look at, there was a pretty big variability in how much FMD improved between participants. So some having sort of a 4% increase in FMD, which might even be sort of a 50% increase. If your FMD was 4% to begin with and it went to 8%, right? That would be a big improvement. So lots of variability. And so the fact that the first improvement predicted the second improvement to training suggests that there might be these reproducible inter-individual differences in our potential to improve endothelial function with this HIIT training and maybe other exposures. And so I think that's really interesting because it suggests, so one, it begs the question, like, why? What are the mechanisms of that? What predicts your response? But then also, you know, are there some people who will respond better to HIIT training, others better to endurance training or resistance training, and so on. And so understanding kind of what drives that, I think, is really interesting. So in that first meta-analysis that I talked about, it was the majority of participants were men. That one was actually about 60-40, so not too bad, but a lot of cardiovascular research is even more skewed to exclude women and include more men. So Lindsay Liu, my current PhD student, is interested in women's health and women's vascular health, and so was curious about what the impact is of exercise training in women, and then particularly postmenopausal women. And there really hadn't been sort of a data synthesis pulling together studies that looked at the impact of exercise training in postmenopausal women specifically, and some studies in older people where really it was predominantly men included. So she did this meta-analysis and systematic review, and it included studies that looked at FMD, so that would be the macrovascular studies here, microvasculature studies, so looking at the endothelial function in the little vessels and those biomarkers that I talked about at the beginning. And overall, about 2/3 of the studies showed that the exercise training resulted in an improvement in FMD. This plot on the other side is just FMD in response to different modalities of exercise, and there was sort of a moderate effect indicating that exercise training did result in an improvement in endothelial function in this population. But there was, again, a lot of variability, and it didn't really seem to be well explained by the type of exercise that people were doing or intensity or anything like that. And so it may relate to more individual characteristics. So for example, whether or not a woman is on hormone replacement therapy or how long it's been since menopause. So again, since there were many studies that didn't find an effect, and it wasn't just due to power. So the effect sizes were actually sort of different in the studies that found a significant effect and didn't. So some more research to understand why this is happening would be helpful, I think. And so all of these studies that I've talked about with exercise and endothelial function have been in the brachial artery. So this is just in here to identify that there is research that shows that exercise also benefits endothelial function directly in the coronary arteries. So in this study, it was 4 weeks of aerobic training. Coronary FMD assessed invasively, and it did indeed increase significantly in the training group. Okay, so then exercise improves endothelial function. By what mechanisms does it do that? So I'm going to talk about 2 linked mechanisms. So the importance of the increase in blood flow associated shear stress that happens during exercise, and then how that might influence expression of the enzyme that makes nitric oxide, endothelial nitric oxide synthase. So this study was exploring how important that increase in blood flow and shear stress is to endothelial adaptations to exercise. So this was done by Burke and colleagues. So they had participants exercise on a stationary bike, and the intervention was 3 times a week for 8 weeks, and they were at 80% heart rate max. And what they manipulated the shear stress stimulus that was experienced in the arms. So even when we're doing leg exercise, shear stress increases significantly in the arms and of course the heart. And so in one arm, they let just shear stress increase as it does during exercise. And in the other arm, they curbed that by inflating a blood pressure cuff to about 60 millimeters of mercury during every exercise session. So the uncuffed arm was experiencing an increase in shear stress during all the training sessions, and the cuffed arm really wasn't. And so we can see here, this is how it was blunted. So the top graph is the sort of free flow arm with no cuff. And we can see that blood flow increased, this is shear stress, increased significantly in that arm. And then in the cuffed arm, that increase was blunted. So these, the top bar and the bottom bar during exercise are significantly different. So we're limiting that exposure to shear stress during exercise. So what happened to FMD? So the dark circles, or the dark squares, sorry, are the uncuffed arm. So the arm that was experiencing an increase in shear stress during each of those exercise sessions. And FMD improved at week 2. In the cuffed arm, where that increase in shear stress was sort of blunted, there was no improvement in FMD. So that would suggest that that increased shear stress exposure during exercise, at least this data suggests that it's really sort of obligatory to seeing that improvement in endothelial function. You may also note, like, wait a minute, FMD only increased at week 2, and then they kept exercising for 8 weeks, and then things got worse again. So that is something that seems to be observed in healthy people sometimes during exercise. It doesn't really seem to happen in clinical populations. And it may be because the artery restructures and gets bigger, and that may impact how much shear stress it's actually exposed to during exercise. But that, that's what we think is going on. And so this study looked at, so fine, shear stress is important. It's responsible for this increase in endothelial function, but what is this shear stress doing? Why is it helping us dilate? So this data is looking at the left internal mammary artery, and this was in patients who were undergoing a bypass graft. And so here we have the training group, and again, it was 4 weeks of training. They were on a bike for about 10 minutes, 3 times a day, and they were exercising at an intensity below their ischemic threshold. And so training improved, and flow-mediated dilation assessed invasively in this mammary artery. And they also, because they were sort of extracting the mammary artery in order to use it for the bypass graft, they were able to get rings of the artery and do in vitro assessment. And so they found that in the training group, the artery segments from that group, they dilated more in response to acetylcholine application, that receptor-mediated assessment of endothelial function, than did artery segments from the control participants. So again, suggesting this improvement in endothelial function with training. But then really interestingly, then they were able to look at eNOS expression in this vascular tissue. And they found that, again, in the training group, eNOS expression, so this enzyme that makes our vasodilator and vasoprotective molecule nitric oxide, the expression of both mRNA and protein was increased in the training group in this mammary artery compared to the control group. And so how does that kind of link back to shear stress? Other studies have shown that when exposed to shear stress, that increases the endothelial nitric oxide expression. So the theory then would go that when we exercise, we increase blood flow and shear stress to fairly systemically, depending on the nature of the exercise. In the arteries where shear stress is increased, we're going to have increased endothelial nitric oxide synthase expression and therefore increased nitric oxide bioavailability. And then that will lead us to be measuring this increased FMD as our index of endothelial function, but also then may mean that we have increased vasoprotection from that nitric oxide exposure and then ultimately decreased risk. So this may be one of the ways in which exercise, again, contributes to cardiovascular risk reduction. So to summarize then, the endothelium is vasoactive and vasoprotective. Brachial and coronary artery FMD are correlated, so we can measure this peripheral limb arterial endothelial function, and it will be hopefully telling us something about what's going on in the heart. Brachial FMD is negatively correlated with atherosclerosis in heart, and there's some evidence that it has some prognostic value for cardiovascular events. Cardiovascular risk factors are associated with decreased FMD. And when you test this peripheral arterial endothelial function with either a transient reactive hyperemia stimulus or a sustained increase in shear stress, that may allow us to detect endothelial dysfunction distinctly depending on what exposure we're looking at. And so it may be helpful to do both tests to get a comprehensive view. Acute exposures, including hyperglycemia and shame, seem to cause transient endothelial dysfunction, and I think we have more to learn about whether that ever adds up to a clinically relevant exposure. And exercise training improves FMD, and that is at least in part due to increased shear stress-induced increases in endothelial nitric oxide synthase expression. So I'll end there and just thank my collaborators and funders, and I'm happy to answer any questions we have time for.
Thank you. That was such fascinating work. So just, I'm going to start off by asking you, you demonstrated so nicely that all the links, sort of coming together. I just wonder, either your lab or in the literature, has there been work done around diseased arteries? So, you talked a little bit about the coronary and that New England paper and so on, but in the brachial system, do you see any differences in patients that have established atherosclerosis? Probably hard to get in if you're using university students to get subjects and so on. But.
Yeah, so I mean, there's lots of data to suggest. So there was that Endothelial, if I'm pronouncing that name right, study where in the patients who had atherosclerosis in the heart, they're then having impaired FMD in the brachial artery. The brachial artery doesn't tend to get plaques, so yeah. But then in coronary arteries, yes, there is data in stenosed arteries and FMDs. I want to say absent, but I'm not actually pulling up a study graph in my head right now. But with infusion of acetylcholine, you get vasoconstriction in arteries that are stenosed. So whether that's the acetylcholine just binding directly to the smooth muscle cells, because the endothelium is just so dysfunctional, and then resulting in a vasoconstrictor pathway rather than the vasodilator pathway, which is activated when they bind to the muscarinic receptors on the endothelial cells. And so you'll get that sort of paradoxical vasoconstriction in coronary artery disease arteries in the heart.
See when we do stress tests and so on. Yeah. Okay. Goodbye.
Thanks. Great summary. Thank you very much. So this is a nice segue to my question. I'm ashamed to say that I have not looked at this literature in like 20 years, but what has always amazed me is exactly what you said, that we can always find endothelial dysfunction in patients with coronary artery disease, but some arteries like the brachial, like the lima, is basically never affected. Like you never see plaques on these arteries, almost never. Whereas others like the iliofemoral system and the coronaries are full of plaques. Do we know why?
Honestly,
I'll get you to repeat the question because I'm not sure everyone. Yeah,
absolutely. Yeah, so great question. We get plaques in our coronary arteries and our leg arteries, but we don't seem to get them in the brachial artery or the mammary artery. And the question is why? And I don't know.
Whereas we do we can demonstrate endothelial dysfunction in those arteries.
Yes.
Like we did similar studies that you showed that, cutting out a piece of the lemma while you're doing bypass surgery, you can show endothelial dysfunction in those arteries, but they don't have plaques.
Yeah, and I don't know. I mean, I know, so the nature of the flow that happens in the artery is important. So if the flow is turbulent or oscillatory at branch points, that's where we tend to end up with more atherosclerotic plaque because of the changing nature of that flow. So rather than it just being laminar, it'll go back and forth or be very low in its mean. And so that seems to result in a change in the morphology of the endothelial cell. So instead of being kind of elongated and where am I, overlapping with respect to the cells, that you'll end up with these kind of more cobblestone-like cells. And so then that allows greater infiltration of monocytes and so on. And so in terms of that regional development, but we have bifurcations in our arm arteries and our leg arteries. So that doesn't seem to explain it, whether the overall like flow pattern is somehow different because of the baseline nature of the vasoconstriction of the resistance arteries that are downstream. So if they're more constricted, yeah, I've never thought about this before, but if they're more constricted, you actually do end up with a more oscillatory flow pattern. So when we do flow-mediated dilation in the leg, and we're just looking at the baseline flow pattern, I'm going to say subjectively here that there's more retrograde flow. So it would be more oscillatory compared to when we measure in the arm. So for whatever reason, the forearm seems to have a more vasodilated vasculature downstream just at rest. And I have no idea what it looks like in a coronary artery, but if it is more oscillatory at rest, that might have something to do with it, because oscillatory blood flow, and that's been shown in cells, and we can induce oscillatory blood flow acutely and result in transient endothelial dysfunction. And again, that whole line of research is really about trying to mimic what's happening at branch points and just understand the impact of flow pattern. But if certain arteries are experiencing, and again, this is very hypothetical, this more retrograde shear pattern at rest, maybe that has something to do with it. And that's just coming from what I see in the difference of baseline flow pattern in the leg, more oscillatory compared to the arm.
Maybe it's from the cardiac pumping.
I mean, the interesting, sorry, but further, the interesting part is that when you attach the lemma to the coronary artery that's disease, and if the lemma goes down, again, it does not go down developing plaques and thrombosis. It basically becomes it's basically peters out to nothing. It's going to be vasoconstricted if there's not enough flow in it. Whereas if you actually suture vein grafts on the arteries, they develop through like two plaques and usual coronary disease in the veins that otherwise never do.
Yeah, so then it's something about the actual artery and the nature of the cells there. It must be, because they're all exposed to the same circulating factors, like the same prevailing blood pressure or cholesterol and so on. Oh, that's very interesting. Yeah.
So Dr. Wang online is asking, what magnitude of improvement in endothelial function might you pose it as being significant in modulating cardiovascular risk? Is there a minimal dose of exercise to recommend for midlifers and beyond? At what rate is benefit lost upon cessation of exercise? That's a few questions.
Okay, yeah, lots of questions. So what magnitude might be beneficial? So I'll come back to kind of meta-analyses, which would look at like a 1% improvement in FMD. Might confer sort of I want to say it varies, but like somewhere between an 8 to a 15% decrease in cardiovascular disease risk. So that's sort of that ratio between how much FMD has to change to influence cardiovascular function. In terms of what was the next part?
Is there a minimal dose of exercise to recommend for midlifers and beyond?
Yeah, I don't think we're at that point of specificity. Also because there's so much inter-individual variability. So you will have kind of non-responders and responders. And so in thinking about, again, that frequency, duration, and intensity, that combination, I don't think we're at the point where we would recommend that. I think what most people would recommend is sort of following physical activity guidelines, like any is probably good and more is better up to a point.
Well, and even the type of exercise you talked about, right? Resistance versus HIIT and all the rest of it.
Yeah.
And then the last one was, at what rate is benefit lost upon cessation of exercise?
Yeah, so in our study over 3 months, it was completely lost. So people went back to baseline, and that was in young, healthy participants. There is other data looking at that rate of decline. I don't have the numbers on the top of my head, but it is kind of a use it or lose it thing. It does seem to abate, and that's certainly true in healthy people. Whether the effects are more longer lasting or less long lasting in a clinical population, I don't know. Sometimes the improvements are bigger in a clinical population because they're starting from a lower baseline, where healthy people might be experiencing sort of a ceiling effect. If their endothelial function is already great, it can only improve so much. But how that impacts rate of decline, I'm not sure.
Well, and you also showed, right, that if you've shown response once, it's predictive for response when you do start up.
Yeah, and that was one of our questions, because it was, all right, so you improve endothelial function, but then a myriad of things can happen in our lives, which then prevent us from exercising. We could get sick, we can get injured, and so on. Are we able to kind of regain that? Does it have an amplifying effect? Like, wouldn't that be great? You train once and then you detrain, but then you get a boost the next time, right? And we didn't find that, but at least the response wasn't attenuated. So you were able to re-achieve the same benefit. Yeah.
Are there any other questions? Otherwise, I have one more. So at what point do you think, and it might be related, saturation is reached, I guess, right? So you showed in multiple studies that there's sort of a point beyond which you don't seem to get benefit. Is there some way of predicting that? Or, you know, you look at some of these elite athletes, or you know, even patients post cabbage or whatever that you know, sort of take on, like, is there some way of predicting where they're at saturation point, where they're really not going to get further benefit?
Yeah, I don't know. And I mean, I guess that's where we would be thinking, if they're exercising or doing some other positive intervention, you know, do you keep increasing the intensity of that intervention? If it's diet, you know, removing more saturated fats from the diet, or whatever the diet intervention might be. If it's exercise, increasing the intensity. And I'm not sure. And again, that comes back to how much variability there is in people's responses to interventions. But one of the things that we've looked at is, because there's an issue of, you know, does your FMD or whatever the index is keep improving, but then there's also how resilient you are to an insult. And so we've started to wonder if sometimes we might do exercise, but maybe we don't see an improvement in FMD because there's a ceiling effect. But maybe after having done that exercise, the person is more resilient to an acute insult. So maybe if we have an acute stress exposure, they don't have as much impairment. If they're exposed to hyperglycemia, they don't have as much FMD impairment. So that's something we're interested in. So we might not necessarily always see that kind of baseline improvement, but there might be a resilience benefit.
So just to that effect, you showed very nicely those studies with individual risk factors. And we know in real life, it's usually cumulative risk factors, right? Are there any in vitro studies that have looked at benefits with cumulative risk factors, or the impact of cumulative risk factors? So, you know, smoking and hypercholesterolemia and genetics or whatever.
Yeah. It's been a while since I've kind of looked at that, teaching a clinical exercise physiology fourth year course, but and again, I'm not picturing the graph in my head, but I want to say that yes, there have been studies that have looked at kind of one risk factor, multiple risk factors, and found that's kind of a graded decline in FMD. But again, I can't call the data to my head, but if I had to guess, I would say if we searched in the literature, we would find that. But again, I can't picture that data as we stand here. Yeah,
really great work. Doing amazing work, and so much overlap with what we do. So on behalf of the Department of Medicine, thank you very much, and really, really enlightening presentation. So thanks.
Great. Thank you very much. It was great to be here.